It is a great pleasure to introduce our next speaker, Professor Lihteh. Lihteh is Associate Professor at the University of Costa Rica and Director of the Asociados de Macula Vitro Retina de Costa Rica in San Jose, Costa Rica. Lihteh is an undergraduate, did his undergraduate studies at Cornell University, then Tulane University School of Medicine, Pew Research Fellowship at the Rockefeller University in New York, Columbia Presbyterian Hospital in New York City, where he did an internship, Mount Sinai Medical Center in New York, where he did his ophthalmology residency. He's been at the National Retina Institute in Baltimore under Doctors Glaser and Murphy, where he did the vitreoretinal fellowship. And he's a fully certified surgeon by the American Board of Ophthalmology. Lihteh, it's a privilege to share this symposium with you. Many thanks.
Thank you, Paulo, for the kind introduction. So today I will be talking to you on whether or not to use anti-VEGFs versus pan-retinal photocoagulation for proliferative diabetic retinopathy. These are my disclosures, of which Quantel Medical is relevant since it's a laser, and Bayer as well. Both of them are relevant. So this audience already knows that PDR, if left untreated, is the leading cause of blindness. Up to 24,000 new cases of diabetic retinopathy-induced blindness occurs each year in the US. So worldwide, that number has to be multiplied manyfold. And without treatment, around half of these eyes with high-risk proliferative diabetic retinopathy will experience severe vision loss within 5 years. So this is a study back from the 70s, late 70s, early 80s, the DRS, which showed that PRP reduces the risk of visual loss compared to observation. And with proper treatment, less than 5% of eyes will develop blindness. So that treatment has withstood the test of time and has been the treatment for PDR over the last 4 decades. It is known that it substantially reduces the risk of severe visual loss. However, PRP is inherently destructive, and one of the side effects is that it will cause peripheral visual field loss, night visual loss, exacerbation of pre-existing DME, and it's not perfect. Around 5% will still experience severe visual loss, which is defined as worse than 5 to 100 at 2 consecutive visits, despite PRP. And more recently, in the past decade, we've seen the use of anti-VEGF drugs, particularly in the use of diabetic macular edema. And we have also seen that in those eyes, the anti-VEGF will decrease the risk of diabetic retinopathy worsening and increases the chance of improved retinopathy level. So it is interesting to see whether or not if one starts treatment of PDR with anti-VEGF, will it delay or prevent the need for PRP? So that is the question. And fortunately, we have a couple of studies that we can look into and guide us with this information. The first study that I'd like to discuss is the Clarity study, which was a phase 2b single-blind non-inferiority trial conducted in the UK. And here we have a little bit over 100 eyes that received aflibercept every 4 weeks for the first 3 months, 3 consecutive, and then they were followed on a PRN basis compared to 116 eyes that underwent PRP from the beginning. Here are the study design and the primary outcome. You can see that this was defined to see whether or not the visual acuity from baseline to a year 52 weeks were different between the 2 groups. And the exclusion criteria, I will call to your attention here that in these eyes, DME was expressly forbidden for the eyes to have DME. Again, this is the design of the study. So here we see two arms, aflibercept and PRP, and then these were received 3 monthly injections of, excuse me, of aflibercept, and then were followed PRN and the PRP arm, and then they were subdivided in groups of whether or not they had treatment-naive PDR or active PDR that had prior PRP. And then they were followed for a year's time. And what were the follow-up and treatment schedules? You can see here, again, that the design of the study was 3 monthly injections, and then patients were followed on a PRN basis. And then in the PRP arm, they were followed every 12 weeks every 8 weeks after the 3rd month. These are the retreatment criteria, depending on whether or not there was regression of the PDR. And you can see if there was complete regression, simply there was no treatment in either arm. If there was partial regression or reactivation in the aflibercept arm, they continue with the aflibercept therapy. And in the PRP, they had additional PRP at the discretion of the investigator. If there was no regression, then the aflibercept arm received also PRP. And in the PRP arm, they just continue receiving laser treatment. Again, this is study. This slide just goes on to show that the groups were well balanced at the beginning of the study. And the results here, we can see that in the PRP group, the patients lost maybe a letter or so. They lost around 3 letters at the end of 52 weeks compared to the aflibercept arm that gained around 1.1 to 1.3 letters. And here in this plot, we can see that in terms of visual acuity, the aflibercept eyes gain more vision than the eyes that receive PRP. And this is on the order of maybe almost a line in best corrected visual acuity. In terms of patients who had gain or losses of more than 2 lines of best corrected visual acuity at a year's time, again, the numbers favor the aflibercept. Here are the gainers and here are the losers. And we can see that the aflibercept eye did better than the PRP arm. And when we look at the disease regression patterns at a year's time, again, you can see that the numbers favor the aflibercept arm, where they had better anatomic results than the laser eyes. These are the eyes that develop macular edema after being enrolled in the study. And you can see that more eyes in the PRP arm develop macular edema compared to the aflibercept arm. And in terms of vitreous hemorrhage, again, the eyes in the aflibercept arm did better than the eyes in the laser arm as well. Here, after 1 year of treatment, you can see that patients receive, on average, 4.4 injections throughout the treatment. And here is the type of treatment that these eyes receive in the laser arm. You can see that about 2/3 of eyes had the multi-spot laser treatment, whether around 1/3 received only the monospot conventional laser treatment. And of all these eyes in the PRP arm, all patients had a little bit over 1 extra laser session needed. So in summary, for the clarity, the mean change in visual acuity with aflibercept therapy was superior to PRP. Fewer patients lost 10 or more letters with aflibercept than with PRP, and significantly fewer patients in the aflibercept group developed macular edema compared with the PRP. There is also less chance of vitreous hemorrhage with aflibercept therapy than with PRP, and the supplemental PRP was rarely required with aflibercept, being done in 2% of patients only. So we move on to the next study, and this is the protocol S from the DCR net. And this study is a little bit different than the prior study. They had longer follow-up. For one, they had follow-up up to 5 years, whereas in the Clarity study, we only had follow-up for 1 year. And here, DME eyes were also included. They were allowed to enroll in the study. So again, the primary outcome was at 2 years, and it was the visual acuity. There are other secondary outcomes that we see listed here in the slide. And for those eyes that had DME and they were enrolled at the beginning of the study, ranibizumab was given, and if the patient developed DME during the study, depending on which arm they were allocated to, one would either use a ranibizumab or focal grid laser according to the protocol I criteria. So in this study, in the protocol S, patients in the PRP group, after the PRP, they were seen every 16 weeks, whereas the patients with the ranibizumab group, they were seen every 4 weeks. And if eyes were randomized to the PRP group and had DME, they had to be also treated with the ranibizumab at the same time. So this is a little bit different from the Clarity. These eyes received 6 monthly injections consecutively. And then at the month 6, they could assess whether or not the neovascularization had improved or not. And you could defer the injections if it was stable, and the injections were withheld if, if everything was stable. They would resume if the patient worsened. The PRP group received the PRP treatment within 8 weeks of randomization. And if they had DME, they had to receive also the ranibizumab. So here, this slide tells us after 5 years, and I'd like to call your attention to the people returning after 5 years. And you can see that both arms, only 60% of patients return. So there's a lot of loss to follow-up in this randomized clinical trial. I will now go over the results at 5 years, and you can see that these are the number of injections that each group received throughout the 5 years. And obviously in the ranibizumab group, there were more injections, but after the first year, the number of injections tended to decrease, whereas in the RP group, on that same thing, they received more injections in the first year and then also gradually decreased as the disease was brought under control. These are the eyes that received PRP during follow-up, and you can see that up to 14% of the eyes with the anti-VEGF received also laser treatment, whereas in the laser group, half of them also received more laser. So the concept of maybe, that you maybe have heard that laser treatment is a one-time deal apparently doesn't hold in this clinical study. Many eyes, around half, will still require laser treatment after the first treatment. And here we look at the visual acuity at 5 years, and you can see the comparison between the ranibizumab arm and the PRP group. And you can see that overall, we had great visual acuities in both arms, 20/25, and they're very comparable to visual outcomes at 5 years in the 2 arms of the study. Here we see the time course of that visual acuity gain, and we can see that at least during the first couple of years, it seems that there was a particular advantage of the eyes that received the ranibizumab compared to the laser, but at 5 years, they were virtually identical, the visual acuities in both arms. When we look at the visual fields, you will recall that with laser, we're destroying part of the peripheral retina. So it is expected that you will have some visual field defects. And indeed, that seems the case when we look at the visual field total point score, that the laser eyes did worse than the eyes that received the ranibizumab. But after 2 years, it seems that the loss in the laser group sort of plateaus out, whereas in the ranibizumab arm, for some unknown reason, there starts to be a visual field decline, and this may have to do more with the natural history of the disease than treatment per se. When we look here at the retinal detachments, again, the PRP group had more retinal detachments than the ranibizumab. When we look at the vitreous hemorrhage, both arms are fairly similar in terms of the degree of new vitreous hemorrhage that occur in these eyes. So the results in summary would show us that are very similar in terms of the visual outcomes between the two groups, and the change in visual field was better for the ranibizumab, although, you know, with time, the ranibizumab arm also had some visual field defects. In terms of the development of DME, you can see here that there were more eyes that developed DME in the PRP group. More eyes underwent vitrectomy in the PRP group, but there were really no big differences between these. So in conclusion, one of the major problems, despite this being a clinical trial, was the loss to follow-up that was very high with these two groups. And the visual acuity in most study eyes that completed the follow-up was very good. The severe visual loss or serious PDR complications were uncommon in either group. And you know, these findings support either the ranibizumab or PRP as viable treatments for PDR. So when we decide to choose which treatment to entertain in each particular patient, we need to take into account patient-specific factors, including anticipated visit, compliance, the number of visits, cost, and the systemic health. There are several advantages of PRP, and one of these is that you're typically able to be complete in 1 or 2 visits. Usually this is often a long-lasting effect requiring no additional treatment. However, as shown in this study, about 45% of eyes had to be given additional PRP after the initial PRP was completed, and it may cost less than ranibizumab injections. There's no risk of endophthalmitis, no risk of systemic exposure to anti-VEGF. What are the advantages of ranibizumab? We see that the advantages is that the visual acuity from baseline to 2 years was no worse than with PRP. They had a superior mean visual acuity over the course of 2 years, and they had good results overall. So this was published in JAMA in 2015. So we have that information, but what happens in the real world? And something concerning has come up, and it has to do with patients that don't show up to clinic. And this is a report from the Wills Eye Clinic, where they follow these patients, over 2,000 patients with PDR that receive either PRP or intravitreal anti-VEGF. And these patients didn't come back for 12 months. And over 4 years, 28% of the patients of these patients were treated with PRP, and 22% with anti-VEGF were lost to follow-up. And when these patients return again, you can see that there was a greater number of eyes that showed up with attractional retinal detachment and neovascularization of the iris in the eyes that had treatment with anti-VEGF than the PRP group. Another paper, this one from the group in Michigan. Again, they looked at different patients that were treated with PRP or anti-VEGF and lost to follow-up. And they mentioned that patients are non-compliant or they had treatment interruption for several reasons. There are listed here. You can see the complications that occur after they return to treatment. And most of these eyes, had visual acuity that was not able to be recovered, with almost half of these patients having a best corrected visual acuity with hand motion of worse. These were the eyes that were treated solely with anti-VEGF and not PRP. And last, what I like to mention is that in the real world setting, diabetic patients underutilize eye care services. They are prone to significant lapses in follow-up. And you can have unanticipated events that can affect even the most reliable patients. In the US, 10 million diabetics are evaluated in the ER annually. Nearly 6 million are hospitalized, and almost half with patients with DME had at least one loss to follow-up up to more than 100 days. And as I mentioned, about a third of patients in Protocol S, despite being in a clinical trial, were lost to follow-up at 5 years. So in summary, the visual loss from PDR has been significantly decreased by PRP, but PRP is inherently destructive, and VEGF inhibitors cause regression of the intraocular neovascularization, but need to be given on a fairly regular basis. And the interruption of anti-VEGF treatment can be catastrophic and lead to irreversible blindness. For those of you who want to delve a little bit more in detail, we sort of reviewed this topic in this publication. I thank you all for your attention.